A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, let me introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These are to improve and maintain the standard of the CPD program conducted by Sri, and thank you in advance for your strict adherence. You can ask questions at the end of the webinar. And if you have very specific questions, you can type it in the chat box. And also you can email us on official13@gmail.com. So today's topic is evaluating kidney stones in children. The guest speaker for today is Dr. Sellathurai Gajendran, Consultant Paediatric Nephrologist, Evelina London Children's Hospital, London, United Kingdom. Over to you, Dr. Gajendran.
Thank you very much, Sri Knowledge Academy, for giving me this wonderful opportunity. I'm really privileged to talk about evaluating kidney stones in children. I'd like to start with a few words of wisdom to begin with. One must be reasonable in one's demands on life. For myself, all that I ask is accurate information, coherent knowledge, deep understanding, infinite loving wisdom. No more kidney stones, please. This is a famous quote by Edward Abbey, one of the famous American author. Why we talk about kidney stones in most of the quotes? This too shall pass. It might pass like a kidney stone, but it will pass. So the kidney stone creates more and more agonies in our lives if we experience it. It's terrible. But what if children are facing kidney stones? So my objectives for today's talk is I'm going to discuss about 5 clinical case scenarios where I've involved in managing them in Evelina London Children's Hospital, and they're having kidney stones. Understanding the etiology of kidney stones in children, and I'm going to talk through about various presentations with varying age groups, those who are presenting with kidney stones, and we will evaluate or how to investigate a child presenting with kidney stones. What are the general management options of a child presenting with kidney stones, and what are the measures to prevent the recurrence of kidney stones? There's an increasing in incidence of symptomatic kidney stones from 7.9 or almost 8 per 100,000 children in 1996 to 18.5 per 100,000 children in 2007, and even more nowadays. So that's the reason we are talking about it. Both environmental and hereditary factors significantly contribute to the risk of kidney stone formation. And we talk about it more and more because children with urinary stone disease, they deserve a meticulous risk factor evaluation. So are we empowered with the appropriate knowledge and thoughts about how are we going to evaluate this to help them? They deserve it. My first case scenario is about a 50-year-old boy who presented to the emergency department with 2-day history of hematuria with some mild suprapubic pain at the time of presentation. There wasn't any preceding history of a sore throat or skin sepsis, no clinical edema noted, and his blood pressure was 100/60, which is normal. His urine dip stick was showing 4+ of blood, 2+ of protein, and 1+ of white cells with no nitrites. So here we have got a boy who came with a hematuria. Obviously, we'll be thinking of whether this could be acute glomerulonephritis as common things first, or this could be a pure and simple urinary tract infection. But the further evaluation revealed, clinically, you're thinking about acute glomerulonephritis as first because no edema, normal blood pressure, and the urine dip is not in favor of any infection. So we did further blood tests. He was having normal renal function test. His creatinine, serum creatinine was normal. We sent off the glomerulonephritis screen, including complements, ASOT, all negative. And we did an ultrasound scan of kidneys, and his right kidney was completely normal. And his left kidney, you can see it was showing a left renal calculi. You can appreciate this area with the acoustic shadowing suggestive of a calculi. So we did the metabolic screening workup for the renal calculi, and he was having high urine calcium creatinine ratio, but the other metabolic screening was negative. So he was directed to urology for further evaluation and management. His CT-KUB revealed a left ureteric stone on top of this renal pelvic stone. He underwent a ureteroscopy and removal of that stone, and ultimately, because the old metabolic screen was negative, he was diagnosed as having idiopathic hypercalciuria. So he has been followed up under nephrologist as well as urologist with some general measures and specific measures we are going to talk about. So this is the first case scenario I'm talking. Commonly, we receive children coming with renal stones. So it's very important to have a combined wider MDT involved in this kind of clinical case scenarios. Not only the treating physician, a urologist or a neurosurgeon is needed here, a fantastic radiology colleague is needed here, and a chemical pathologist is needed here. We're moving on to the second case. This is somewhat different. A 3-year-old boy with left-sided multicystic dysplastic kidney and having a right kidney which has upper pole cyst with 2 lower pole stones. Why this is different? Left-sided multicystic dysplastic kidney. Multicystic dysplastic kidney means there's no active kidney tissue in that left-sided kidney. So the sequelae would be that left-sided multicystic dysplastic kidney commonly is going to regress and is going to atrophy and then vanish. So this child is purely going to have a right-sided single kidney. And even in that right-sided single kidney, if you can see in this image, there is a upper pole cyst. I'm pointing with the arrows, and this is the lower pole area. And the radiologist did some maneuvers to find out this lower pole is having 2 stones. So this is the difference why we talk about only single kidney, all the interventions and everything going to reflect in the kidney function. We need to preserve his kidney function as much as possible with whatever the appropriate surgical intervention. And he needs to be managed medically to prevent further kidney stone formation and deterioration of kidney function. It is a challenge, and it's a bit scary. You have a single kidney and almost the upper pole cyst is occupying, which is a simple cyst. So there's no much intervention needed in that aspect. But this child is under combined follow-up with urologists as well as nephrologists. This is somewhat different from the first scenario where they present acutely. Now we move on to the third clinical case scenario. A 2-month-old baby boy, 35-weeker, presented to the local hospital with poor feeding and poor weight gain. History is further revealing that he's been having several wet nappies in a day, crying excessively for feeds throughout the day, was treated for early neonatal sepsis, recent gastroenteritis, clinically found to be lethargic and dehydrated. Baseline bloods on admission were showing elevated creatinine. So his kidney function is deranged, you could appreciate, with high urea, slightly high potassium, and there's a metabolic acidosis you can appreciate with the bicarb of 14.4 and raised lactate as well. So what are the thoughts if you receive a baby like this? We know we're going to dig into the history further, whether this child had any parental nutrition, any other antibiotics, especially nephrotoxic medications like gentamicin. We did the ultrasound scan of kidneys. They were showing large echo-bright kidneys. So nephrocalcinosis, if the radiologist is explaining it as mild nephrocalcinosis, that is different from large echo-bright kidneys, which is a bit worrying. So we reviewed the images. With this clinical scenario, impaired renal function, it could be a dehydrated or septic child here with a recent gastroenteritis. That's also possible. You need to hydrate. That's the first step after your initial assessment. And then obviously we did the ultrasound scan. This is not normal. So this is scary, isn't it? So increased echogenicity, this is called large echo-bright kidneys. So we know there is some solid deposition. So in children, if they present this earlier, we always think about, could there be a metabolic or a genetic etiology here, which could be treated? So I'm going to show you the trends of investigations during the course of management. This, on the left-hand side, is the kidney function or the serum creatinine over the course of hospital stay. And on the right-hand side, urine oxalate to creatinine ratio. So why I'm talking about this is this child was having an echo-bright kidneys. So we are going to do the metabolic workup. And the metabolic workup revealed very high, significantly sky-high urine oxalate to creatinine ratio. So you're suspecting, oh, this could be primary hyperoxaluria. With the initial management, you can see increasing the fluid intake, the creatinine, which was getting better, and coming to a baseline of about this, still not normal. And then over the course, even though with the management, with the medical management and general measures, the urine oxalate to creatinine ratio is significantly coming down. It's still very high, but the creatinine started to go up, or the kidney function started to get deranged. It's worrying, isn't it? So we did the genetic panel. We sent nephrocalcinosis gene panel and tubulopathy gene panel, which confirms the diagnosis of primary hyperoxaluria type 1. So for the treatment, why the creatinine is also going up with our general management, we started with some pyridoxine to see, even though the urine oxalate is coming down, the kidney function is getting worse. So this child was transferred to Great Ormond Street Hospital for further treatment with lumasiran, which is a double-stranded small interfering RNA, which reduces the production of the enzyme glycolate oxidase, which is involved in the synthesis of glyoxylates and oxalates, thereby reducing the urinary and plasma oxalate levels. That is a different scenario, which is quite complicated, isn't it, compared to those previous ones. Now we move on to the clinical case scenario number 4. This is a 31-weeker, a baby girl, antenatally detected polyhydramnios and slightly echogenic kidneys. Postnatally found to have hypokalemic metabolic alkalosis with poor weight gain. So the differentials would be, we know hypokalemic metabolic alkalosis with hypercalciuria is going to be Bartter syndrome. So are we suspecting, what are we suspecting here with the initial evaluation? And I'm going to show you this ultrasound scan of kidneys. You can appreciate the echogenic areas with significant nephrocalcinosis here in the premits. And this is the kidney function of this 31 weeker. From the time of admission, the creatinine was high. With our management, it's nicely coming down to a baseline of creatinine of 30s, and that's stabilized here. The genetic diagnosis came as type 1 Bartter syndrome. So the management of Bartter syndrome, we all know the pathophysiology of what's happening around it. I'm not going into the detail, but they're having polyuria. We are replacing. They need to have free access, isn't it? They need to be hydrated well. We need to make sure they are growing well. So most of the babies will be having an NG tube, pop-up feeds to gain. So this one, I had to start 260 mils per kilo per day of fluids to keep a steady state of growth and to keep the kidney function stable. And I'm following up in my outpatient clinic. So this Bartter syndrome is somewhat different, and already you have this nephrocalcinosis inbuilt because of the hypercalciuria. So you need to have some gentle measures to see the progression of this kidney disease. If we are not managing meticulously, they're going to go into chronic kidney disease. So this is the last clinical case scenario, case number 5. I think if there's any nephrologists on the call, they're going to love it. Very challenging, complicated case scenario. Let us go through about it. A 6-year-old boy presented to the local hospital with generalized abdominal pain, on and off temperatures, and reduced urine output. His clinical examination revealed cervical lymphadenopathy and a splenomegaly. So here, with the initial first set of bloods, the creatinine was 529 micromoles per liter, and the potassium was high, urea was high, high phosphate, slightly lower, albumin level, scary. So the general pediatrician was ringing during my service on-call week this kind of picture. So we know the temperatures, lymphadenopathy, splenomegaly, there's an infectious etiology obviously going on. And this child is now having a significant AKI and oliguria, and then suddenly, oh, no urine output now. So we did the right thing by asking them, come on, send them in. Transferring to our center, anuric for more than 24 hours. And we, did the ultrasound scan. Even the local ultrasound scan was showing only mild increased echogenicity of both kidneys. They said mild bilateral nephrocalcinosis, no hydronephrosis, having an empty bladder. So empty bladder with the catheter in situ, no urine coming. So we know with the catheter, there's no hydronephrosis. So post-renal AKI is excluded. With a background of infectious etiology needs to be considered. Could there be any intrinsic AKI as a cause? Is there any pre-renal element? So they were giving fluids and now, boys getting edematous as well. So you have addressed the pre-renal causes. Intrinsic one, no focus of infection, but CRP slightly elevated. What are we dealing with? So what does this child need? So as a treating clinician, the thoughts would be, the child needs a dialysis, a form of a renal replacement therapy, isn't it? Because anuric now for more than 24 hours. Creatinine is going up. The next set of creatinine came as 600s. Urea is going up, so needs a form of a renal replacement therapy. And the ultrasound scan was showing normal sized kidneys with slightly increased echogenicity. So you need to go for a kidney biopsy as well. So he needs a general anesthesia, and he needs a form of a access, could be a vascular access or a peritoneal dialysis catheter, and he needs a kidney biopsy. That's a general outline. But something is not right here. What is that? So something is not right. That's why we need a wider MDT. So it was really interesting. It was really challenging in this case scenario, but we had to discuss with the urologist and the radiologist to go for a detailed assessment. So the that nephrocalcinosis is the one warranting very, very remotely or rare chance of bilateral ureteric obstruction. What are the odds? But still, it could be a chance, bilateral ureteric obstruction due to this, whatever the gravels or the stones slodging. But you will be having a hydronephrosis. But this child is already having an established AKI, so you won't be seeing the dilatation there. So what happened was we asked the urologist to come and help us. So there was a plan made to go for. This is a very miserable child with temperatures, and there's a picture of, infectious cervical lymphadenopathy and splenomegaly picture. With this creatinine, and you won't believe, after 3 days, he went home with a creatinine of 38 without needing a form of a renal replacement therapy or a kidney biopsy. What happened? So can you see this image? On admission, the creatinine, we did something, and then 12 hours later, the creatinine came down less than 150, 100 on the next day, 38, went home the day after. So this is the finding. So we asked the urologist, come on, take this baby or child inside the theater, go for cystoscopy and bilateral ureteric stenting. If you get some urine output, that's good. So we don't need any form of a renal replacement therapy. If you don't get any urine output, or if there is no obstruction, then we would go for a vascular catheter access for a hemodialysis, and we'll come and do the kidney biopsy. That was the plan made. So here you can see bilateral vesicoureteric junction is completely occluded with some funny gravel material. So when they did the scope, like gravel, kind of a brownish murky material is coming out with pouring of urine. That was their observation. So this child had bilateral ureteric stent insertion and then significant diuresis. This is called post-obstructive diuresis. The part of main management would be you are going to replace all the fluid, otherwise you're going to create another pre-renal kind of an AKI. So he passed more than a couple of liters of urine on table with this. So there wasn't any need of a renal replacement therapy. There wasn't any need of a kidney biopsy. On top of that, the investigations came. So the bilateral ureteric obstruction, obviously, is an emergency. Urologist did the wonderful thing, bilateral stents in situ, and then later, next day, the EBV viremia was positive, which is going to the reason why he was having these low-grade temperatures and lymphadenopathy as well as splenomegaly. And we did the metabolic screen for this. So all the metabolic screen negative. We have sent the nephrocalcinosis gene panel, and ultimately that came as autosomal recessive infantile hypercalcemia type 1. How strange is that? And he's under the follow-up with urologist as well as myself in the outpatient clinic with a very stable creatinine of less than 40 now, with some general measures to prevent further kidney stone formation. We'll be talking about that. Right. Now we're moving on to evaluating kidney stones in children. Bit of a boring part of theory aspects. What causes kidney stone? And how are we going to approach? A detailed history is extremely important. As doctors, we try to listen to the parents, we try to get more from the child, and there is a set of laboratory testing, including urine as well as blood tests and the imaging. Our lovely radiology colleagues need to tell us like the appropriate imaging to come and find out. And with the urologist, we are going to manage this. Metabolic risk factors in children with kidney stone disease. An update found on the Pediatric Nephrology Journal, International Pediatric Nephrology Association. They have done a retrospective registry study of 300 children with kidney stones, And they evaluated the risk factors with urine and blood sampling, and they did a metabolic assessment. They found idiopathic hypercalciuria as a main cause of kidney stones in children from the metabolic point of view, followed by hypocitraturia, hyperoxaluria, hypomagnesuria, hyperuricosuriia, unduly acidic urine, and cystinuria. So they've concluded, given the common occurrence of metabolic disorders in children with urolithiasis, thorough biochemical testing is essential for the diagnostic as well as the metabolic changes. And then to guide us with a specific preventative therapy, which is very important, isn't it? So what are the causes of urolithiasis? So we all talk about common things as hypercalciuria, as I have discussed those clinical case scenarios, which may occur in the context of they can have normocalcemic hypercalciuria, hypercalcemic hypercalciuria. Among them, idiopathic hypercalciuria is being the most common cause of hypercalciuria. And then they could be having increased salt or sodium intake, which leads to distal tubular secretion of calcium. So they could have hypercalciuria if you eat more salt. And there could be vitamin A, C, D excess or intoxication, immobility, whatever, the various forms of hyperparathyroidism, ketogenic diets, malignancies with paraneoplastic effects, sarcoidosis, and that's, the list goes on. Inherited disorders affecting the tubules. As we talked about the Bartter syndrome clinical scenario, there are so many other inherited disorders which could cause nephrocalcinosis or kidney stone disease. You can see the list goes on. And the metabolic disorders and abnormalities, particularly, as we already talked about, the baby or infant presented with primary hyperoxaluria. There could be secondary hyperoxaluria, idiopathic hyperoxaluria, cystinuria, hypocitraturia. And there are so many disorders of purine metabolism where you're going to get purine stones. Xanthine or urate stones, you're going to get them. The difference is they are radiolucent stones in compared to the others as radio-opaque stones. We'll come back to that in detail. Medications is a lot of medications could cause this, but we focus on mainly diuretics like loop diuretics. Furosemide could cause hypercalciuria. Steroids could cause hypercalciuria. So the common referral we always get from the neonatal units is this neonate is having mild nephrocalcinosis. How are you going to manage, or what are the follow-up options? So if you dig into the medication history, you'll be finding out on steroids for whatever the respiratory conditions, on furosemide, so then they could be having hypercalciuria and nephrocalcinosis. So the preventative measures you'll be advising, you need to stop or taper it and stop it, hydrate them well, and then plug into the follow-up and repeat the scans later to see whether that is getting better. So it's very important to get those, medication history in detail to find out what could be the causative agent for this nephrocalcinosis or stone formation. Risk factor evaluation is very important, especially in hot climates. Low fluid intake, we know the urinary concentration and supersaturation is going to cause solutes to deposit. So that's the main risk factor. Hydrate them well. So everyone with kidney stones, we know, will be calling about, we need more and more fluid intake. And the diet, if the diet is having high salt and high protein, you're at risk of having kidney stones. Immobilization, mainly because of reduced bone mass, leading to increased calcium excretion. Augmented bladders, bladder stones could be happening in augmented bladders due to retention of mucus and bacterial colonization to think about. So there are risk factors we need to address. So it's very important to know there are inhibitors of stone formation and there are promoters of kidney stone formation. Citrates, magnesium pyrophosphates, uromodulin are inhibitors of kidney stone formation. Calcium, oxalate, phosphate, urate, cysteine, there are so many promoters. They're going to cause crystal nucleation. They're going to come closer together, supersaturation, crystal growth, and then agglomeration. So if you detect nephrocalcinosis early, by hydrating them, you're going to prevent the further steps going down and to kind of clear them. So it's very important to have general measures because we'll be thinking always we need to give a medication. It's not. So you won't believe more than 90% of children with kidney stones in our clinics, they're not on any medication. Only with the general measures, we could be preventing further stone formation. Now we are coming to the history taking, the basic steps of initial evaluation, detailed birth history, including prematurity and medications, which may have given in the neonatal period. So mainly, if the baby or neonate is on total parenteral nutrition for a long time, which could be a risk factor of nephrocalcinosis. They have received steroids, they have received furosemide, any antibiotics like ceftriaxone. So why that is very important with when you have the drug history as well. Consanguinity, the parents are consanguineous, we need to know there could be a genetic etiology going on here. And drug history, we talked about family history of nephrocalcinosis and urolithiasis is very important in familial cases. Renal impairment, any of the family members underwent renal replacement therapy or dialysis, kidney transplant, any hearing problems, especially in distal renal tubular acidosis, you can have hearing problems, especially in Bartter syndrome type 4, you can have hearing impairments as well. So it's very important to have a detailed history taking. Presenting features. So kidney stones can present with, varying symptoms in children. Nausea and vomiting, frank or microscopic hematuria, passage of a stone or a gravel-like sediment, abdominal or flank pain, or referred pain, temperatures or dysuria. They can present like acute kidney injury in our clinical case scenario that we discussed. The physical examination may reveal costovertebral angle tenderness. Stones are often found incidentally in children as well. So now we're moving on to urinalysis. So the urinalysis is very important to detect whether there is an infection. So common things first. We're seeing urine infection with significant leukocytes and nitrites, and we know there could be an infection with this presentation. We need to treat and see the particular urine infection. If there is any associated structural abnormality, your urine infection can cause infectious stones, struoid stones. We'll talk about that with the coming slides. Urine microscopy assessment for crystals. Yeah, we can see under the microscope, oh, this is the particular thing paused in the urine. Urine culture will come as positive, then you're dealing with the infectious etiology. The urine biochemistry, obviously in children, it's really hard to collect a 24-hour urine sample. So you can send a spot urine sample for urine calcium creatinine ratio, urine oxalate creatinine ratio, urine cysteine creatinine ratio, urine urate creatinine ratio, and citrate creatinine ratio. You need to know what kind of a metabolic issue this child is having. If you're suspecting cystinuria, you'll be sending urine amino acids as well. So this picture was showing some uric acids, crystals, calcium phosphate crystals, oxalate crystals. So we can see different kinds of crystals under urine microscopy, which could help us in leading to a particular diagnosis. And blood tests, obviously, Serum creatinine, we need to know the kidney function, what's the potassium, what's happening with the chlorides. So we know hypokalemic acid-base status is going to give us a different clue towards a particular diagnosis. Kidney function is very important. There could be an obstruction, or there could be deranged kidney function to detect. Magnesium, phosphate, calcium, mainly bone profile is very important. Urates or any purine disorder markers. Vitamin D levels, could be this be vitamin D excess. Blood gas, we talked about. Full blood count and CRP if you suspect infection, or you're going to do any surgical interventions, you need a coagulation screen and a group and save. Like the last case scenario we discussed, we were thinking about doing a kidney biopsy and a vascular catheter insertion and a surgical intervention. So we need to have this kind of coagulation screen and a group and save as well. Genetic testing, if you suspect an inherited disorder, it's always worth sending genetic testing. And then if you detect, or if you got the stone, so determined by the underlying cause of the stone formation. So mostly you can have calcium oxalate stone in about 45 to 65%, calcium phosphate stones, 14 to 30%, and these struride stone or the magnesium ammonium phosphate stone, about 13%, which could be the infectious stone. Cystine stones, usually it could cause bladder stones. Urate stones in 4%, mixed or miscellaneous stones in 4%. Stones less than 5 millimeter can usually pass through the urinary tract spontaneously. This 5 to 7 millimeter, 50% likelihood of spontaneous passage, and more than 7 millimeter unlikely. So we tend to have a combined urology, nephrology, and radiology MDTs. They're discussing about this clinical case scenarios and the stone measurements and stuff. Like this could be the general advice. So managing a child with kidney stone, acute management, relieving the pain, and hydrating them. So mainly 1.5 times of maintenance fluid is needed, either form of IV or oral, to hydrate them well. And then if surgical treatment is needed, they will be going for a surgical treatment with the help of urologist. And what are the measures we are going to talk about preventing the recurrence? For all patients, high fluid intake, so at least 2 liters per meter squared, especially in hot climate countries, it's very important to push them more to have at least 2 liters per square meter of body surface area of fluid intake to prevent further stone formation, which is very, very important. At least 1.5 times of maintenance, they say in other guidances. So hypercalciuria will be giving calcium as per the recommended daily allowance, not excess, not low calcium. I'll be coming back to that point later in my slides. Avoid excessive animal protein, which is, critical and crucial or controversial because children need protein for their growth, but we need to avoid excessive animal protein. Low sodium diet, that's very important. High sodium diet is going to cause hypercalciuria. Thiazides, if dietary measures fail, we'll be talking about that in our next slides. Potassium citrate or neutral phosphates can be tried in hypercalciuria. So if you are thinking of primary hyperoxaluria, you're going to avoid high oxalate foods. You're going to give some potassium citrate, neutral phosphate. In pyridoxine responsive patients, you can give supratherapeutic doses of pyridoxine to help, and then monitoring for extrarenal involvement. Later on, they will be needing renal replacement therapy and combined liver and or kidney transplants, and then lumocitinib as a case that we discussed before. Targeted treatment for hyperuricemia, we are avoiding high protein diet. Urinary alkalization can be tried, potassium citrates, allopurinol, or febuxostat. Cystinuria, You're going to avoid high protein diet and urinary alkalization, potassium citrate, like that. The targeted treatment is differing. So the main thing is detecting it, acutely managing it, referring to a particular nephrologist and the urologist to tackle with the particular diagnosis. Targeted treatment option is very important. So if a child is less than 5-year-old with kidney stones or nephrocalcinosis, the history is very important to know whether there is a consanguinity here, medical evaluation, any phenotype analysis coming as positive, dysmorphic features or anything, diagnosis established in the clinical certainty, we are proceeding with best available treatment. And we are evaluating for the response. If the response is adequate, that's fine. Inadequate, we are considering genetic analysis. If there is consanguinity, send for the genetic analysis and medical evaluation for phenotype analysis, and we are establishing diagnosis. No diagnosis found, proceeding with the best available treatment and evaluate for the response. If a child is more than 5 years, medical evaluation and phenotype analysis and diagnosis established within the clinical certainty, we are proceeding with the best available treatment, evaluating the response, whether that is adequate, then that's fine. Inadequate, we are considering genetic analysis. These are flow diagrams of thinking of genetic analysis in children. So if you suspect renal stone by history and examination, you're going to confirm it by ultrasound scan, do the kidney function test. If you suspect obstruction or deranged kidney function, ask a nephrologist and a urologist help. And if there's no obstruction, normal kidney function, we all need to know we need to have the metabolic evaluation, nephrology and urology opinion. Stone passed in urine, we can send the stone for chemical analysis. And then if there is nothing like that, as we discussed, the blood test and urinary metabolic screening is coming into practice. So we are repeating the test for abnormal parameters. One abnormal result doesn't mean anything, but general measures are very important. The European Association of Urology recommends the following surgical options for children. So single urethral stone, less than 10 millimeter, can be managed with shockwave lithotripsy if localization is possible. Ureteroscopy is an alternative if that is not feasible or unavoidable. So for stones, 10 to 20 millimeter, shockwave lithotripsy can be offered. More than 20 millimeter in size, percutaneous nephrolithotomy can be offered for renal pelvic or calyceal stones, including staghorn stones. It's a bit of a surgical aspect, but we're not going into that detail. So this chart, this image is going to show you if you have detected a calcium oxalate stone, there could be these associated conditions. If you detect calcium phosphate stones, there could be some associated conditions. Likewise, uric acid stones, steroid stones, mainly infectious cause, cystine stones could be cystinuria. We need to think about what is the stone, what could be the associated condition. If you detect particular metabolic abnormality, you need to know the initial treatment option, reducing the dietary sodium, dietary calcium at the recommended daily allowance, not in excess, not low, thiazide diuretics for hypercalciuria. There are indications if hypercalciuria is severe or there is osteopenia, when your general measures fail, you can go for thiazide diuretics. And second line treatments with potassium citrate, trying to alkalinize the urine, not over-alkalinize. We'll come back to that in the next slide. Thiazide diuretics or neutral phosphate can be tried. Hyperoxaluria, obviously, we're going to reduce the dietary oxalates. We're going to try some potassium citrates. And there are second line treatment options as well. If there is hypo-citric aciduria, that's why you're doing urine citric acid range. So it's very, citrates is low, you're going to give some potassium citrates, and second line, you can add on some bicarb as well. Hyperuricosuriaria, You're going to alkalinize with potassium citrate, and as a second line, you can try allopurinol. Cystinuria, again, alkalization, reducing the dietary sodium, and you can try medications like penicillamine later. So this is the image of showing particular metabolic abnormality. You can try with the initial treatment, and you can go for second line treatment. Now we move on to the general recommendations. Increasing fluid intake, that's the very important thing. We all know whoever having kidney stones, drink more, drink more, drink more. But certain guidance or guidelines say minimum 125% of normal maintenance. But I would say the climate like Sri Lanka, we need to go for at least 2 liters per meter squared of fluids, or more than 1.5 times of maintenance of fluid intake, which is tricky in children. You need to try to push. They won't drink that much, but that is the way forward. Avoidance of fizzy drinks, especially if they drink more fizzy drinks, they're not going to drink the milk or any calcium containing products. Low calcium also not going to help. It's going to create more phosphate stone formation. Decrease intake of animal protein. Again, a controversial one, but we can try, but we need to give as per the recommended daily allowance. Not in excess, just try to reduce it. Restricted salt intake, we talk about that. Normal calcium intake, we talk about that. Reduce intake of food rich in oxalate, and we need to treat the underlying disorders, particularly cystic fibrosis. Potassium citrate might be helpful even in the absence of hypocitraturia, because you're alkalizing the urine, and try to prevent further stone formation. I'm going to ask a question. Can a child with a kidney stone, now you have done some general measures, urology measures, and the parents are asking, can we give king coconut water? Can we? Just think for a while. We'll come back to that at the end of the talk. Specific recommendations for calcium stones, we talked in a separate image. I'm trying to emphasize again, with specific management options, you're going to give specific treatment. We can't overdo things, we can't underdo things. So calcium stones, uric acid stones, oxalate stones, cystine stones, and struide stones, the specific considerations are different. So we need to have an idea on what about this? What is the metabolic composition, and what are we dealing with? What are our first line? What are our second line management options? So this is, again, a busy slide with increasing the liberal intake, obviously, as we talked about, and particular struide stones, infectious stone, treat the UTI. Cystinuria, what are we dealing with? Hypercalciuria, again, we need to stop the causative agents. Most of the scenarios, they'll be on high doses of furosemide. They'll be on high doses of steroids for other conditions. So we can't say, just stop it. So they need to evaluate, try to wean off, try to reduce, coupled with some dietary modifications and general measures. Hypocitraturia, what are we going to do for that? Can add some lemon juices for the water, try to give, because you're giving more sources of citrates. Hyperuricemia, acute lowering medications and chronic lowering medications can be considered by clinicians. Hyperoxaluria, for secondary hyperoxaluria, you need to restrict dietary oxalates. And xanthinuria, so those are different kind of conditions. Different metabolic conditions need to deal differently. And then again, another basic slide, just to tabulate and summarize the things. With the history, examination, initial investigations, how are we going to track down our management plan? When are we going to deal with this? When are we going to discuss with the urology and the metabolic workup screening? And the chronic management, as we discussed, any causative agents should be stopped if possible. Liberal fluid intake, dietary advice for those with hypercalciuria, adding lemon juice to the water as a source of citrates, avoid carbonated drinks, salt restriction, maintaining normal calcium intake for children. For those with cystinuria, again, salt restriction, reduction of methionine intake. You know, the foods high in methionine include certain fish, tuna, dried cod, and shellfish, liver, poultry, beef, cheese kind of thing. So if we try to reduce the methionine intake, you're going to try and prevent further cystine stone formation. Realistically, you're trying to maintain the urine pH between 7.5 and 8. You can't overdo the things, and you can't alkalinize further beyond 8, then you're going to risk a phosphate stone formation. Medications, thiazide diuretics should be considered if hypercalciuria is persisting without hypercalcemia and our general measures fails, and if there is any bone hypodensity. So osteopenia is associated, then you can try thiazide diuretics. Volume depletion is stimulated by thiazide, which promotes both sodium and calcium reabsorption in the proximal tubule, thereby reducing urine calcium excretion, which is wonderful to know what's happening with your diuretics. It may induce hypokalemia, so we'll be checking serum potassium levels, and we could supplement potassium as well. Citrate, that is typically given in the form of potassium citrate, because we need some potassium as well, should be considered in recurrent stones, more than 50% calcium oxalates, and for those with hypercalciuria, hypocitraturia, and cystinuria. Cystine binds intestinal urine calcium and increases urine pH. It is converted to bicarbonate in the liver and also works as a urinary alkalizing agent. Increased urinary pH allows for increased urinary calcium solubility and aiding excretion. That's how citrate works. And potassium supplementation also will inhibit distal sodium reabsorption, and that is acting like reducing urine calcium excretion. As we talked about vitamin B6, especially in pyridoxine dependent primary hyperoxaluria patients, you can give higher supratherapeutic doses of pyridoxine. You can try chelating agents, especially in cystinuria. You're going to give some penicillamine. Uric acid lowering agents can be tried. Oral administration of neutral phosphates and magnesium preparations which bind to urine calcium and oxalate respectively may reduce the risk of forming stones. So key points to discuss at the end of the talk: kidney beans for thought. For every 100 millimole increase in sodium, there is 1 millimole increase in urinary calcium, right? So hypercalciuria, reduce salt intake. Increased dietary potassium, that reduces hypercalciuria and increases the urinary citrate. High protein intake from meats increase uric acid, calcium, and oxalate levels, which reduces citrate levels. Low calcium intake can increase the risk of stones by forming phosphate stones that we talked about. Drinking sugar beverages that can't be as a substitute of milk, because milk is a source of calcium. Topiramate, which is another anti-epileptic, which could cause some stones. In hypercalciuria, excessive alkalinization is a risk factor for phosphate precipitation. So as a summary, pediatric urolithiasis, it is becoming a common health problem worldwide. The causes: environmental, dietary, genetic, but think of metabolic etiology in children. Metabolic risk factors, mainly hypercalciuria, needs to be considered. Diagnostic evaluation should aim to rule out anatomic obstruction and determine the risk factors. Therapy should be targeted at the risk factors causing urolithiasis, also while simultaneously general measures to increase the fluid intake. Prevention of stone recurrence involves regular education. So these are the references, and thank you very much. Any questions I'd like to answer if I can.
Thank you very much for the informative lecture, Dr. Gajendran. There are a few questions in the chat box. So one is, what about lime and citrus fruits?
Sorry, I can't hear you clearly. Can you repeat the question, please?
Yeah, sure. What about lime and citrus fruits?
Yes. So, we need to, that's why I said, as I said, lime, adding some lime to the water will give some citrate. That is very helpful as a general measure to increase your citrate in the urine. That is going to alkalinize the urine. So that's very helpful to add on.
The next question is, what is the place for shockwave lithotripsy?
So that's also, I think I mentioned that in one of my slides as a surgical options, depending on the size and depending on the location of kidney stones, the central or the peripheral ones will be considered. That's as case by case scenario we liaise with urologists. So shockwave lithotripsy is indicated in certain scenarios with particular stones in the periphery. Yes, there is an indication.
Next question is, how long should we continue potassium citrate?
So it's all about our metabolic workup. So if there's no right or wrong answer to see particular, time or when do you need to stop. If you see hypocitraturia, you are adding the potassium citrates and you're monitoring the citrate level in urine. And if you're preventing further recurrence, you'll be continuing it. And if it's a trial of, try to stop it and see if you continue to hydrate very well, then there's no risk factors. The hydration itself is enough, and then you're trying. After some time, you're trying to stop it and see. There's no right or wrong answer of when or how long.
Then we have few questions which have been sent before the lecture. So you have answered most of the questions, sir.
Thank you.
There's one question, that patient and family education in children with renal stones.
Exactly. So that's very important to have that family history evaluation to screen for any familial tendencies of having kidney stones and renal replacement therapy and kidney failure. So we need to have if you find out any familial tendencies, there is always a place for diagnosing genetic condition and give genetic counseling. And family education is a must because parents won't be pushing that much with regards to general measures because they will go to another doctor who gives them medication. So they will doctor shop to get a medication to cure this, but that's not the case of general measures. We need to hydrate, hydrate, hydrate. And these, fine general measures of adding some citrus fruits or whatever to prevent further stone formation. So we need to talk more with our families to prevent further stone formation as a risk factor if there is something like that.
Then there's another question, how to treat UTI in PGP setting.
Pre-GP settings. So urinary tract infection. So I think this is a straightforward question about if you detect the urine dipstick is showing features of leukocytes and nitrites in the urine dip and send a UFR to detect pus cells, then with a clinical kind of scenario with urinary tract infection symptoms, you're trying to treat it after sending a urine culture.
Then there's a final question about emergencies in kidney stones.
Yeah, as I mentioned in my talk, obstruction is an emergency. So if you detect, that's why the ultrasound scan comes first. In my clinical case scenario that we discussed, bilateral ureteric obstructions or even unilateral obstruction could cause a clinical picture of type 4 renal tubular acidosis, where you get hyperkalemic, no melanine gap metabolic acidosis. As medical personals, we will be detecting those biochemical derangements and we will be directing it to the urologist to relieve the obstruction. Unless you relieve that obstruction, you're not going to solve this type 4 RTA or hyperkalemic metabolic acidosis picture. So we get more and more referrals about why this child is having hyponatremia, hyperkalemia, and there is a metabolic acidosis. And when you do an ultrasound scan, sometimes a calculi will be blocking in the upper pole, and there is hydrocalicosis significantly. Unless you resolve that, this metabolic picture won't be resolving. You'll be supplementing with sodium, and you'll be doing general measures to bring down the potassium and giving some bicarb to create the normal neutral environment, but that's not going to deal. So it's an emergency obstruction. You need to direct to the urologist. Thank you.
Thank you very much, sir. So our sincere thanks to Dr. Sellathurai Gajendran, consultant pediatric nephrologist, Evelina London Children's Hospital, London, United Kingdom, for his excellent lecture and the precious time.
Thank you very much.
Okay. Dear participants, kindly find the link in the chat box and kindly fill that and give your feedback and answer the post-assessment question, and then you will receive your e-certificate for participation. Thank you, everyone.